And warm welcome to our MedEClasses lecture series. And as we've discussed earlier, is basically this is every monthly lecture series which we organize with regards to the postgraduate learning program. And this series will be talking more about obesity, which is going to be a very, very important topic that we are seeing importantly in terms of childhood obesity, which is increasing, and there are various issues with regards to that. I'm really honored to have Dr. Somana who is with us, who is part of our team, and she has been very actively involved in promoting pediatric endocrinology in West Bengal. Dr. Somana is faculty at the renowned Vivekananda Institute of Medical Sciences, Kolkata. Dr. Somana, welcome, and thanks for sparing your time on this weekend. She will be sharing her expertise about the overall topic. I've also got Dr. Sayan Banerjee, who is a fellow in our Department of Regency Center for Diabetes, Endocrinology and Research. And the way these programs are structured is that we will be discussing initially a bit about theoretical aspects, and then we'll go forward with regards to the question and answer session. So before we start off, Dr. Somana, we like to have your views about how important obesity is as a topic or overall in terms of both clinical relevance for both postgraduates as well as for the pediatric trainees.
I mean, it is one of the most common cases that we find in our OPDs, and it has gone up tremendously, especially after the post-lockdown and COVID pandemic. As we know, obesity has been increasing, and it is a global pandemic anyway. And often the postgraduates, when they face a child or an obese child, most of the times I have seen that they are in a hurry to investigate, send a lot of investigations. But there is a logical approach to the child so that we don't run into unnecessary investigation and over investigations. And that is what I think is important here. That is where I think this series is going to help them to have a logical approach. And it is one of the very important topics in terms of exam too. I mean, every year almost there will be some questions or the other about obesity.
So we had the 16-year-old boy with obesity who presented with significant obesity, and we can see the height was 165 centimeters. The BMI was significantly elevated, and the child actually had a waist circumference which was 126 centimeters, and we can see a lot of acanthosis which was already there. At that point of time, some basic evaluation was done, and that evaluation showed a TSH which was mildly elevated. Started on thyroxine, and everybody was happy that now, okay, we have got this thyroid issue and we can manage it accordingly. 1 year later, after starting thyroxine, presented with frank complications of type 2 diabetes along with non-alcoholic steatohepatitis. Now, this is a very, very common situation wherein people are diagnosed as hypothyroidism based upon just a minor elevation with regards to TSH level. The treatment is initiated, and that often is not the cause, because this is the effect of obesity and not the cause of obesity. And this is something which we'll discuss subsequently. So this was one situation where we unnecessarily created a pathology out of physiology. Now, this was a 12-year-old girl with obesity. Again, this girl was obese, but what we're noticing compared to the first boy is that she was short. Her height SDS was -2. So this is a short and plump child. All the screening tests were normal. She was advised lifestyle measures and now presented with rapid weight gain. So if we compare with the first case where we had made a pathology out of physiology, this was actually a pathological cause, which was considered as a physiological cause. And by the time the child came to us, she had frank features of Cushing syndrome, and evaluation and management confirmed the diagnosis. So the key aspect as far as the evaluation and management of obesity as was discussed by Dr. Somana is with regards to not doing too much workup where it is not required, but to do workup when it is very, very important in that regards. So we are seeing obesity pandemic. It's a very, very common problem. 10 to 15% of population across affluent studies will show you 98% of children who have obesity have a physiological cause. So only 2% will have a pathological cause. The key focus in this scenario is to identify individuals who have a physiological cause, who do not require evaluation, while not missing a pathological situation in that regard. So there is a careful need for assessment and management in that regards. So in this lecture series, we'll be talking a bit about physiology, what causes obesity and how obesity interacts with different hormones. Then Dr. Sumana will discuss about the criteria and etiology. I'll go forward towards approach, assessment, and management, and then we'll have the Q&A with Dr. Sumana about the various questions which usually may come in terms of pediatric examination in that regards. Now, all of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information with regards to different aspects of pediatric endocrinology. You can have access to our e-learning modules, which are there in the YouTube, and we'll be posting these videos as well very soon with regards to these summaries. We have got a comprehensive validated program for learning in pediatric endocrinology with tools and practical assessment in that regards, including fellowship programs, which are a hybrid online on-site program over a 2-year period, and pediatric endocrinology for postgraduate, which provides a 3-year access to our common modules that we're discussing, the entirety of 40 modules which are there in that regards. We also have 3 specific aspects which are there in terms of grand rounds. So we do have a postgraduate grand round. We have endocrinology grand round regarding more complicated cases. And finally, this monthly postgraduate lecture series, which aims to cover the entirety of pediatric endocrinology over a 3-year period, which we're going to cover. You can also access our publications, both basic as well as advanced pediatric endocrinology, and have a look at a mobile application available on both Android and iOS stores, which provides a comprehensive information about each aspect and practical tools to identify bone age and growth interpretation. So without wasting any more time, we'll be focusing about physiology of growth hormone, obesity. And what we need to understand is that when we talk about obesity, we talk about fat. So fat is actually a stored form of energy. So whenever you're talking about fat or adiposity, we need to understand that this energy, which is stored in the form of fat, is coming mostly from the food intake. Now, this food intake could be as part of what is required for survival, could be for something like pleasure. So often we eat as far as some party or some other activities, or as part of stress. So whatever you take is in the form of the intake, and what you spend out of it is basically in the form of the resting energy expenditure, as well as which depends largely upon the lean body mass and physical activity. So the net difference between the intake and the output, the excess energy, is stored in the form of the fat. So when we talk about specifically with regards to obesity, we're talking about increased level of energy. So obesity is essentially a balance issue with regards to the energy in that regards. Now, most conditions which call obesity are largely because of increased intake. Reduced expenditure is there. It is a contributory part, but it's largely increased intake, which is causing the entire problem in that regards. So we need to really understand as to what really controls our intake. And one of the very important markers which comes out, which is basically a marker of energy status in the body, is leptin, which is adipocytokine, which is produced by the fat cells, which provides the information about how much energy in there in that regards. Now, the whole process of this appetite or eating, and I've said that eating is a major factor which regulates the overall process, requires a close interaction of pathways which cause hunger on one side, which are the orexogenic pathways, and the pathways which you are going to say, okay, now you have enough to eat, and they will cause suppression, the anorexic pathways in that regards. And the main processing unit of all this is in the hypothalamus. So mediobasal hypothalamus is the central processing area. In the ventral medial hypothalamus, the arcuate nucleus and the nucleus tractus serratorius, these are the regions which actually are the major determinants about how much we're going to eat in that regards. So they are the anorexic pathways, which are the POMC pathway, and the orexogenic. So the anorexic pathways are activated when we have enough level of energy, and they will say, okay, we do not need to eat. And the orexogenic pathway will be stimulated when the energy levels are low in that regards. Now, how does the body know that the energy levels are high? The signals start right at the time when you're eating. So when there is a distension of the abdomen, the vagus nerve will be suppressed, and that will cause more appetite. In situations where the stomach is not distended, the stomach sends a signal called ghrelin, which will then demand with regards to the intake of food. And once the food intake comes in, there will of course be distension, and the ghrelin levels will go down. The other signals which will tell us whether we have got enough energy are the level of nutrients in the body, the energy in the form of ATP, and some intestinal signals, the most important of which are the known as incretins, the GLP-1. Now, this GLP-1 is secreted once the food reaches the duodenum and body says, okay, now we have had intake, we should shut down, and it will really activate the anorexic pathways along with neuropeptide Y and cholecystokinin. Pancreas also produces insulin, which again would be produced only when the glucose levels are high, and it will say, okay, the energy intake is less, along with amylin. And as discussed earlier, the adipocytokine leptin, which is the most important marker, so to speak, as far as the energy status is concerned, is going to then have an effect on the anorexic pathway. Now, there is also an efferent pathway, which really controls the energy expenditure. So the energy intake and expenditure are both correlated very closely in that regards, and this efferent pathway is regulating the energy expenditure. Now, what we need to understand, and this is very important from a clinical perspective of evaluation, that obesity has a huge impact on a number of hormonal systems. So obesity has a definite impact on the thyroid system. Essentially, when somebody is becoming obese would mean that there is a lot of energy in the body, a lot of fat in the body, and body will like to utilize that energy. So in the setting of obesity, leptin levels will increase and they will try to induce a hyperthyroid state, so as to allow the loss of energy. It will stimulate TRH, it will stimulate TSH, but the mechanism will fall there. Despite all these efforts, a thyrotoxic state is not produced. So in a very important perspective, obesity has an effect of increasing hypothalamic action and TSH level. And this TSH elevation is therefore the effect of obesity and not a cause of obesity. Now, as we showed in the first case, a large number of children will have subclinical hypothyroidism, TSH between 4.5 to 10. In the setting of obesity, these do not require treatment because it's not going to help in that perspective. So this high TSH, normal T4, normal T3 is the classical picture which we see in the setting of obesity. It's a compensatory response which improves with treatment. And definitely, if you correct obesity, it will improve. There is no need of thyroxine unless there is a TSH which is more than 10, or there is evidence of autoimmunity in the form of TPO positivity. So we'll see this example of a 12-year-old boy whose height was reasonable, was obese, and bone age was also normal. Now, TSH was 7.91, was advised treatment. So if you look at the oral analysis and interpretation of this child, he has a constitutional. He is a tall and obese child, doesn't require any evaluation and management in terms of thyroid perspective. So this TSH of 7.91 is actually the effect and not the cause of treatment, and we need to follow up, and in most cases it will improve over the next 2 months or so in that regard. Now, how does obesity influence growth? And this is where we need to understand, because it has huge implications as well. So in situations where the body fat is more, the body will perceive we got more energy, and we can use this energy for very important work which are energy intense, and growth is of course energy intense work. It will cause an increased level of insulin because of insulin resistance. This insulin will reduce the insulin-like growth factor binding protein, increasing the free IGF-1 level. So obesity is associated with increased IGF-1, causing increased growth. So therefore, obesity is associated with increased growth. Every child who is obese should be tall. If you have a short child with obesity, you're dealing with an endocrine issue like growth hormone deficiency, hypothyroidism, pseudohypoparathyroidism, or Cushing syndrome in that regards. Insulin also has a direct effect in that regard. So overnutrition is resulting in a greater production of IGF-1. And theoretically, when your IGF-1 goes up, the growth hormone levels will go down, and you may have a false diagnosis of growth hormone deficiency in terms of that regard. So obesity is associated with rapid growth. Decreased growth is very, very important. So this is the fundamental paradigm when you're evaluating a child with obesity. You expect that a child who is tall, whose height age is more than the age, has a nutritional pattern of obesity, while if you have a growth chart like this, in which your height is compromised, you have a short and plump child, like the second case we discussed, is clearly an endocrine cause, which is very important from that regard. Now, besides the growth and thyroid, there are significant impact on the hypothalamic pituitary axis. And this is very, very important because in obesity, there is a peripheral production of cortisol. The activity of 11 beta HSD, which activates cortisol, increases and the cortisol levels goes up. So therefore, obesity is quote unquote a pseudo Cushing's disease. So often, as discussed, we will get the cortisol level assessed in children with obesity and we'll find the level to be high. This does not mean that the child has Cushing syndrome. It's just because of obesity that the cortisol levels have gone up in that regards. Now, leptin will also go up. It will have an impact on the insulin sensitivity. So the cortisol production will go up in that regards. There will be high cortisol as we discussed in this setting. So we had a 14-year-old girl with obesity. Blood pressure is 120/80. There is some pigmentation. Cortisol was high. ACTH was in the normal detectable range. And then somebody thought this is a ACTH dependent Cushing syndrome, and MRI showed a pituitary adenoma. Now, do we agree with this diagnosis of a ACTH secreting pituitary adenoma causing Cushing syndrome? No, this cortisol elevation is actually the effect of obesity. And this is basically, we should have done an overnight suppression test to get a diagnosis, and overnight suppression was really normal in that regard. So this highlights the importance of how obesity can result in a confusing hormonal picture of hypothyroidism, growth hormone deficiency, and hypercortisolism. And all three of them will ultimately have causing obesity as an adverse effect in that perspective. But what is important to understand is that on all three of these conditions, be it hypothyroidism, Cushing syndrome, or GHD, the height is less. So because your child's height is normal, it makes these possibilities very, very unusual, and don't get confused in that regards. Obesity has a significant impact of puberty in girls, and it's known that because of higher level of leptin, the kisspeptin pathway increases, and there is a greater chance of entering puberty once the body has a trigger. So the pubertal onset becomes a bit earlier in obesity. However, very importantly, because obesity causes peripheral production of estrogen, this may also cause earlier pubertal onset. It also disrupts the overall pituitary axis, resulting in a disjuncted puberty. So the classical effect of obesity on puberty in girls is that you will have earlier onset of thelarchy, but the gap between thelarchy and menarche is increased. And this is very, very relevant from that perspective. Very important factor also to remember is that often these girls may have lipomastia, and often the diagnosis of precocious puberty in obesity is a false diagnosis. It is not really gynecomastia. It's not really a precocious puberty, but just a lipomastia. What about boys? As we have discussed that in girls, there is a disjunction between thelarchy and menarche. There is also a disjunction in boys between pubarchy and gonadarchy. So in the setting of obesity, because of increased leptin levels, there are peripheral production of estrogen goes up because of that perspective, and that suppresses LH, causing a suppression as far as a central precocity, central development is concerned. So there seems to be a delayed puberty, but because the adrenal axis is activated because of insulin, there would be a pubic hair growth which will happen. So you will have a classical example of pubarchy which is there with small testicular size. So in a way, obesity causes significant impact of puberty in both boys and girls. In girls, it largely presents with a situation of early thelarchy with a prolonged onset of menarche. In boys, it causes pubic hair growth, which may be precocious, but puberty will be delayed in a gonadarchal angle. So we had this 12-year-old boy with pubertal concern. He is in the obese range. SPL is normal. The testicular volume is prepubertal. There is stage 3 pubic hair development. The investigations show everything is normal. So this is a classical example of this adrenarche-gonadarche disconnect. And whenever you have an adrenarche-gonadarche disconnect, you will automatically have gynecomastia, which will happen in this perspective. Now, we are all very, very concerned about complications of obesity. So what causes those complications is essentially the overspill of body fat. Whenever we take fatty acids or energy, we know that till a particular level, the body can store it in the subcutaneous tissue. Once the level of the fat overcomes this cutaneous storage capacity, it goes to be deposited in the visceral areas of the liver and the pancreas, inducing not only causing fatty liver and gallstones, it also causes insulin resistance, which is the primary secondary drivers in terms of obesity complications. And these would include type 2 diabetes, polycystic ovaries, hypertension, dyslipidemia, sleep apnea, intracranial hypertension, and a lot of other complications which are there. So in an essence, when we talk about obesity complications, we're talking about a greater amount of fat load than the storage capacity of the body. So individuals who are small for gestational age cannot store enough amount of fat in that perspective, because their capacity to store is less. So they at a lower weight level will have more metabolic complications as compared to somebody who is AGA or SGA, and that becomes very, very